Sure, let's start actually. Thank you. So good evening, everyone. Thank you for joining us this Sunday evening. I would like to welcome you to this year's first CME program for the year 2026, organized by the Medical Education and Continuous Professional Development Subcommittee of the College of General Practitioners of Sri Lanka. I'm Dr. Kala, and I'll be moderating this evening's CME session. A few housekeeping rules. We will continue to stay muted during the time the talk's going on, but do feel free to share any questions you have on the chat. And at the end, there'll be time to ask some questions. And also those who have registered and who are in the talk will also be given CME points at the end. Now, I have the pleasure in introducing the speaker, who is actually my friend and colleague, Dr. Sabith Salieh. Dr. Salieh graduated in medicine at the Royal College of Surgeons in Ireland and went on to complete his medical internship in Singapore. His postgraduate medical qualifications are Master of Medicine in Family Medicine, obtained from the National University of Singapore, and international membership of the Royal College of General Practitioners, the MRCGP International. Dr. Salieh obtained his specialist registration as a family physician with the Singapore Medical Council and has over 18 years of clinical experience as a medical practitioner. At present, he is the Director of Caretech Health Private Limited. He is the Joint Secretary of the Independent Medical Practitioners Association of Sri Lanka. He also serves as the Secretary of the Primary Care Diabetic Group, Sri Lanka, and is a lecturer for the certification course in evidence-based diabetes management conducted by PCDG and Public Health Foundation of India. He is a council member of the Vaccine and Infectious Disease Forum of Sri Lanka. He's an associate member of the College of General Practitioners of Sri Lanka and is currently the convener for the Medical Education and Continuous Professional Development Committee of the CGPSL. He also serves as a member on the Occupational Health, Public Relations, and Social Activities Committees of the College. Dr. Salieh is an examiner for the MRCGP International South Asia Postgraduate Examination in Family Medicine. He is also a tutor and a group facilitator for the Foundation of Family Medicine one-year online certification course conducted by the MRCGP International South Asia Board. So that's about Dr. Salieh. Now over to you for your presentation.
Thank you very much, Kala, for the kind introduction. So I would like to thank the president of the college as well as the CME and the Medical Education Committee for inviting me to conduct this webinar. I think we've got an interesting topic, metabolic associated fatty liver disease, something that is very relevant in GP practice nowadays. So I think it's important as GPs that we learn to, obtain the clinical knowledge to see how we can apply it and manage our cases competently within a primary care setting and know when to refer them out. So it's I've just got about a little over 30 slides for you, and we'll be happy to take the questions at the end. So let's start. All right. So we thought we'll start off with a slide that where you have a classification or where we talk about the division of fatty liver. Initially, it was divided to alcohol-related liver disease and non-alcoholic fatty liver disease, right? And this is an older term which is now slowly being replaced. In 2020, there was a new term coined, metabolic associated fatty liver disease, and now this in 2023 has slowly being replaced by metabolic dysfunction associated steatotic liver disease or MASLD, right? And then in 2023, there was also a new term coined, metabolic dysfunction and alcohol related liver disease, MET-ALD, right? So we'll over the next few slides, you will get a better understanding of the classification. So when you talk about the older version, in some of the slides, I will still use the old word because some of the data and the things are quoted using the old term. And as we progress, we will move on to the new terminology. So when you talk about MASLD, a lot of us think that if you consume alcohol or even a small amount of alcohol, you should be classified under alcoholic related liver disease. That is not the case. So if you look at the diagnostic criteria or the criteria to diagnose MASLD, you could consume a small amount of alcohol where, for example, if it's less than 3 units for males or less than 2 units for females, right? So, and when you talk about a unit, one standard unit is about 10 grams of alcohol based on the WHO standard units. Whereas when you talk about alcohol-related liver disease, the daily alcohol intake should be more than 6 units for males and more than 5 units for females. And this is, remember, these are daily units, not weekly. When you talk about MET-ALD, that is the newer classification, they had where you have one metabolic risk factor, which I will explain to you over the next few slides, as well as a daily alcohol intake of between 3 to 6 units for males and 2 to 5 units for females. So what do we normally mean by a unit? So for example, if you take 150 ml, a glass of wine typically contains 12% of alcohol, that's about 1.5 units. If you have a 30 ml shot of liquor, typically 40%, that's about 1 unit, and a 330 ml beer, a can of beer, which is typically about 5% of alcohol, is about 1.3 units. Okay, so why is non-alcoholic fatty liver disease? If you look at the stats, right, the global prevalence is about 25%, or it could go up to about 40% in certain regions of the world. It is the most common chronic liver disease in the world. It is estimated to become the leading cause of liver transplants globally by 2030. If you look at the local prevalence in Sri Lanka, it is about 1 in 3 would have fatty liver in an urban population setting. Rural population estimates are around 18%. And I think the more concerning fact is about 8.4% of the urban adolescents are affected by NAFLD, right? So this is extremely worrying. And if you looked at some of the data from specialized liver centers, which showed 63% of liver transplant referrals were due to NASH cirrhosis, and 59% of liver cancers were secondary to NASH cirrhosis. So, and the other concerning fact is over 50% of potential liver donors are rejected due to NAFLD. So this is, I think, if you just look at this slide, you will understand that we're dealing with a silent epidemic. Okay, and why it should not be ignored. So historically, I think, fatty liver has been there for a long time. It's usually an incidental finding that people do not pay much, both even the patient and even doctors did not pay much attention about it. It was very much a benign approach, right? But why it should not be ignored is because the risk of developing type 2 diabetes, now this is based on a local study, showed that there's a twofold increased risk in developing type 2 diabetes, and the prevalence of NAFLD in type 2 diabetic patients is up to about 75%. The prevalence of NAFLD in severe obesity can reach up to about 90%, right? And the CVD or your CVD risk factor is a major contributor to mortality in the NAFLD population. So this is something that is very important, where we need to look in certain at-risk groups and screen them actively for fatty liver. So if you look at the definition, it is defined by an excessive hepatic fat deposition, that is what we termed steatosis, based on either imaging techniques or histology. We don't do histology often, right? It's quite an invasive procedure. And so once you have evidence of steatosis in the absence of excessive alcohol intake or other secondary causes. Now, here I've underlined the term excessive. So you could have a small amount of those who consume a small or mild to moderate amount of alcohol and do have fatty liver. They can still be classified as the older term non-alcoholic fatty liver disease or metabolic associated fatty liver disease. Now, it is important to understand that it is a spectrum, right? Because you can have, majority of them will have simple steatosis or simple fatty liver. About 10 to 30% can develop what we call non-alcoholic steatohepatitis, which is inflammation. The newer term is MASH, metabolic associated steatohepatitis, where you have a fat deposition with inflammation. And then you can have liver fibrosis or scarring, and that can lead to cirrhosis. And of course, you're at a high risk of developing hepatocellular carcinoma. But just remember, it's not a linear progression. So for example, you may have fatty liver, you may not develop MASH or NASH, and you can develop fibrosis. Similarly, you may develop, you don't have to develop cirrhosis to have hepatocellular carcinoma. You may, from fibrosis, develop hepatocellular carcinoma straight. It's rare, but these things can happen, right? So just remember, it's a spectrum. Okay, so if you look at the nominee culture or the term that has been used now, non-alcoholic fatty liver disease was used. I mean, it's been there for a long time. It was coined in the 1980s. It requires an evidence of steatosis, so imaging, biopsy, or validated biomarkers, and this was mainly a diagnosis based on exclusion. So you had to rule out alcohol and other causes, right? So the problem with this is you may miss patients with mild alcohol intake or multiple etiologies. So it is still being used, but rare. And the newer term, metabolic associated fatty liver disease, which was coined in 2020 by Eslam et al. And proposed by the MAFLD consensus group. Again, you need you would have
We
alcohol,
can't.
other secondary causes coexisting. Can you hear me?
Yeah, now we can hear, but you went off for a short while. Yeah.
All right. So where did you lose me?
From the requires
Metabolic
evidence of
association.
steatosis.
It requires evidence of steatosis. So this is mainly a diagnosis-based inclusion. So it is pathophysiologically centered, and so you could have alcohol and other secondary causes that can coexist, right? So the relevance of this is you can identify high-risk groups. So it captures high-risk metabolic and fibrosis-prone groups, and this is now slowly gaining traction across research and clinical guidelines as well as global consensus bodies. Now, the newer term that was coined by it was introduced by the European Association of Study of Liver, the European Association of Study of Diabetes, and the European Association of Study of Obesity. The term was metabolic dysfunction associated steatotic liver disease. And this is what is now slowly replacing MAFLD. And when you talk about metabolic dysfunction and alcohol related, MET-ALD, this is where you combine both of them, where they have moderate intake of alcohol, plus if they have one or more metabolic risk factors, dysfunction risk factors. MET-ALD, the prevalence is about 1.7. I would think it's about 5%. The 17% was based on a Danish study, but in general, there was a study in the UK which showed the prevalence of being about 1.7 to about 4.5. And in South Korea, there was a study within a primary care setting which showed a prevalence of about 5.6. Okay, so if you look at the risk factors, genetics does play a part, right? There are certain genetic mutations. A well-known or a well-studied form is your PNPLA3 genetic mutation, which is located in the long arm of your chromosome, I think on chromosome 22, and mutation of this results in the loss of triacylglycerol lipase enzyme activity, and as a result you have accumulation of fat in adipocytes and liver cells. And the important thing to understand with genetically predisposed individuals who have this PNPLA3 mutation, it is not only the risk of them developing fatty liver, but there is a significant link associated with the progression of the fatty liver from a simple fatty liver to MASH or fibrosis. Right? Being overweight is a risk factor, overweight or obese. So when you look at your BMI, the Asian cutoff is 23. So overweight is if your BMI is more than 23, you're categorized in the overweight category. If your BMI is more than 28, you're in the obese category. Insulin resistance is a huge factor. Type 2 diabetes, so even pre-diabetes is a risk factor. And dyslipidemia. What do I mean by dyslipidemia? Where you have high triglyceride levels and low HDL. So low HDL levels below, say, 40 for males and below 50 for females is considered low. I've mentioned there lean MAFLD and lean MAFLD. So this is an older term where we found that patients who were not obese having fatty liver, and we no longer now have a separate entity. This is included in the MAFLD diagnosis, but I just put it out there because some of us may have read it or come across this term previously. Okay, so if you look at the diagnostic criteria, so you need to have evidence of steatosis either in the form of imaging or biopsy, and one of the following. So if you are either overweight, right, or if you have type 2 diabetes, or if you have metabolic dysfunction. So metabolic dysfunction, you need 2 or more criteria to qualify. So we talk about an elevated waist circumference, high blood pressure, hypertension, if a BP is more than 130/85, hypertriglyceridemia, low HDL, basically dyslipidemia, pre-diabetes, evidence of insulin resistance, or elevated high sensitive CRP, right? So these are the diagnostic criteria that we use for MASLD. Now, we have to remember that there can be certain conditions that are associated with fatty liver, type 2 diabetes, like I mentioned, dyslipidemia, metabolic syndrome, polycystic ovarian syndrome, obstructive sleep apnea, hypothyroidism, and hypopituitarism. So it's important when we come across patients with these other diagnoses, we must think of fatty liver. Okay, so symptoms wise, majority of them are asymptomatic, right? It is virtually a silent disease. Fatigue, malaise, pain on your right upper belly area or the right hypochondrial area, all of these very rarely occur. And during late stages of NASH, MASH, or cirrhosis, then you could have symptoms or signs of decompensation, right? But majority of the time, the patient would be completely asymptomatic. Now, when we talk about the pathophysiology, this is multifactorial. This is a very complex slide. So I know that there's a lot going on there. So I've just simplified the processes in this slide for you. So when we talk about the pathophysiology, there are a few things that we need to understand. So typically, a diet high in calories and fructose significantly is a risk factor and indirectly induces lipotoxicity. What we do know is in the MAFLD or in fatty liver patients, there is what we call an upregulation of HMG-CoA reductase. So there is increased de novo lipogenesis, right? So lipogenesis is basically a metabolic process where your body creates fatty acids and triglycerides from non-lipid sources such as carbs in the liver and in muscle, in liver and adipose tissue. So what happens is there's an increased amount of free cholesterol, an increased amount of lipid deposits, and this forms crystals and drives inflammation. The other thing that happens is there is a disruption in the bile acid metabolism. Now, bile acids function as they are an important component of your signaling molecules, right? So you have your farcinoid X receptor and your Takeda G coupled receptor 5 receptors. So what happens when in fatty liver patients is you have deactivation of these receptors. So deactivation of the FXR receptor results in increased gluconeogenesis, increased lipogenesis in the liver. Your deactivation of your TGR5 receptors end up in increased insulin resistance. And what happens is when you have insulin resistance, and when you have increased amount of free fatty acids, that further enhances insulin resistance, and this causes an oxidative stress with the release of pro-inflammatory cytokines, and this alters your IKKB, which is an important regulatory kinase. It stands for inhibitory kappa B kinase beta, which is an important regulatory kinase, and this is responsible basically for progression of simple fatty liver to MASH or NASH or fibrosis, right? Now, the other thing that we know is, I mean, when you consume a fructose high diet, and also we talk about this new thing about intestinal dysbiosis or the shift in your gut microbiome. So there are a lot of ongoing research and studies to link your gut bacteria with many disease processes. But what we do know is when you have a bacterial overgrowth in your gut, this produces an increased amount of endogenous ethanol, and that causes an increase in your intestinal leakage and increases your circulatory endotoxins like LPS, which is lipopolysaccharide, and these affect your liver Kupffer cells to release reactive oxygen species or ROS and other pro-inflammatory cytokines such as TNF-alpha, interleukin 6, and these in turn activate your hepatic stellate cells to produce, and these are the ones that end up producing a lot of collagen and starts the fibrosis process, right? So this is just to give you a rough idea of what the pathophysiology of MASLD is. So when you talk about investigating a patient, right? So we need to understand that when we think about, so a lot of them are found incidentally. So they would do an ultrasound abdomen, and then they would say fatty liver grade 1, 2, 3, 4, right? I'll come back to that. Again, that grading system is just a rough approximate. It's not quantitative, right? But it tells you, and it's very subjective as well to the experience of the radiologist performing the scan. So they come with this thing of fatty liver. So when you identify or when you screen for someone for fatty liver, you have to screen them for other metabolic abnormalities as well. So look at the BMI. Remember, in an Asian context, don't just focus on the BMI. In Asia, we tend to have a lot more less muscle mass, and we tend to have a lot of visceral adiposity, and that is the main cause of things like fatty liver and cardiovascular disease. So talk about your waist hip ratio, right? So typically for males, you would have the ideal target is a waist to hip ratio of below 0.9. For females, it's below 0.85. Check the blood pressure, do their fasting blood sugars. If the patient can afford it, get an HbA1c done, because an FBS initially during pre-diabetes and certain, insulin resistance, or what we talk about when you have a lot of insulin resistance, your fasting blood sugar levels may be still normal, and it's the postprandial levels that initially may rise. So they may have normal fasting blood sugar levels, but on their HbA1c, they may be in the pre-diabetic range, right? So if they can afford it, get an HbA1c done. Look for markers of insulin resistance, so acanthosis nigricans, skin tags at the neck, your armpits, right? Get a cholesterol panel done, lipid panel, liver function test. Now, when you talk about liver function test, remember, you can have a perfectly normal liver function test. It doesn't mean that the patient may not have MASH or NASH or cirrhosis or fibrosis, right? A normal liver function test doesn't tell us anything, but in some patients, you would find a mild increase in the GGT, right? And that is a good marker, because when you talk about fibrosis markers, GGT is actually sensitive. It's not a fibrosis marker, but it's a sensitive marker of oxidative stress and metabolic dysfunction, and it's often the first to slightly increase before the ALT. ALT is also commonly seen later on, and if you suddenly see your AST levels going up more than your ALT, that is of concern, because that tells you there is significant, the fibrosis process probably has started. And of course, we'll do a full blood count to check for your platelets as well, right? Now, apart from screening for metabolic abnormalities, the other thing that we need to remember is, what are we most worried about when we're dealing with a fatty liver patient is there fibrosis, right? So I think that is important. So when we talk about management of fatty liver, we need to screen them for fibrosis. So that can be done in many ways. It can be done through scoring systems, imaging, biomarkers, and of course the gold standard is liver biopsy, but that is not done on a regular basis. So when you talk about scoring systems, the APRI score, which is mainly done to assess cirrhosis, so it's not very much validated in the MAFLD population. The NAFLD fibrosis score is used, but it is good to be used in a secondary care setting, because there are a lot of you need certain information like the BMI, your albumin levels, your sugar levels, your AST to ALT ratio. So all of these things may not be available to us in the primary care setting. Whereas a FIB4 score is something that has been well validated for MAFLD patients to be used in a primary care setting, right? So that is very easy. When we talk about imaging, so that's the first thing we would use. If you suspect someone or someone who is having fatty liver and you want to screen whether they have fibrosis, we may start off with a FIB4 score. There are imagings. We'll come to that in a minute. When you talk about biomarkers, I mean, these things may not be readily available in developing countries, and it may come in at a huge cost. There are biomarkers for fibrosis, such as hyaluronic acid, your tissue inhibitor, metalloproteinase 1, and your P3NP. These are biomarkers which are used overseas in Western countries as well, or developed countries. Now, when you talk about the FIB4 score, I've used, it's basically a calculator, and you can see it on the right hand of your screen. It's it was designed originally for hepatitis C, hepatitis B, HBV. Hello? Yeah.
I'm good, mom.
Kindly mute the mics, please.
Yeah. So when you talk about, sorry, I think there was some, yeah. So when we talk about the FIB4 score, right, this was originally designed or validated in hepatitis C and hepatitis B patients when they were assessing, estimating the liver scarring and whether they need a biopsy or not, right? But this has been validated in non-alcoholic fatty liver as well now. And if you look at all you need is the patient's age, the AST, the ALT, and the platelet count. You put that in an online calculator and you would get the number of points. So here it's calculated as 1.41 points. I'll talk to you about the interpretation in the next slide, but I just want you to just want to highlight two things. One is this is a very easy score or screening to be done in. It can be done in a primary care setting. The other thing is you have to remember with all these FIB4 scores, the purpose of this is to screen somebody with or to rule out advanced fibrosis, right? Not to really diagnose fibrosis. Okay, you'll get a better understanding of it when I explain it to you a little later during the other slides when we talk about the fibrosis stages. The other limitations we need to remember when we are using the FIB4 score is that the population or the validation of the study, the participants were between 35 to 65 years, right? So if anyone is below 35 years, you may have false negatives. What do I mean by that? You may miss advanced fibrosis. And if it is in very elderly patients, more than 65 years, there is a chance of having false positives. So, or you overestimate the fibrosis risk. And as a result, you may have unnecessarily, sending them for further investigations, screening investigations for fibrosis and unnecessary referrals. So sometimes when dealing with more than 65-year-old patients, they've taken the cutoff instead of being 1.37, they've pushed it back to 2. But this is something you just need to be mindful of. Now, how do we interpret the FIB4 score, right? So this is basically, if you get a score of less than 1.3, we identify this as low risk and you can manage the patient in primary care. If it is between 1.3 to 2.67, this is indeterminate, right? And you need to offer them a second line test, right? In terms of second line test to assess or screen for fibrosis. And if the score comes more than 2.67, then automatically they fall into the high risk group and you would need to, you can straight away refer them to a specialist without even thinking of doing a second line test. So this is what I've just shared with you in the earlier slide. So you do your risk score stratification, and then you can come up with what disposition that you need to do based on your risk stratification, right? So when we talk about, for those who are indeterminate, we go to the next option of screening, which is basically either a liver stiffness measurement by elastography or an ELF blood test. What do I mean by ELF? Is enhanced liver fibrosis blood test, which I've spoken to you about, the hyaluronic acid, your TIMP1 and H3NP. Remember, the other thing that we need to remember is when you have certain subgroups of patients, which I've told you, for example, type 2 diabetics, or if they're very, very obese, your BMI is more than 40, multiple metabolic risk factors, or they have genetic factors such as your PNP, PNLPA3, there are rapid progression to fibrosis. So you need at the risk of them having simple fatty liver and progressing into MASH or fibrosis is much faster than, say, someone who does not have those risk factors. Okay, so when you talk about liver elastography, so part of the liver assessment, when we talk about fatty liver, like I told you, when somebody does an ultrasound abdomen, they come up with this fatty liver term grade 1, grade 2, grade 3. That is just a rough estimate of the liver fat. Now, it doesn't tell us much clinically, right? Because it's very subjective based on the radiologist's experience. And also you need to have a significant amount of fat. I mean, for small amounts of fatty liver, the ultrasound scan may not pick it up. And the other thing is it's non-quantitative. So grade 1, grade 2, grade 3, grade 4 doesn't mean anything in that sense. But when we talk about fat, so I'm just going to, when you talk about fat assessment, then ultrasound, apart from the ultrasound abdomen scan, there are other better scans such as your fibroscan, or if the best one is what we call an MRI PDFF, which is proton density fat fraction, but we don't do those because of the cost. But when you talk about screening for fibrosis, or you talk about the the stiffness, right? That is what we talk about, the liver elastography, and this is what we are screening for fibrosis. So when you talk about liver elastography, there are three types. You have your ultrasound liver elastography, which is basically shear wave elastography, and that is commonly what we. So if you write ultrasound liver elastography, this is what they do, and then the technology that they use there is your AFRI, the acoustic radiation force impulse technology. Vibration control transient elastography. This is the technology that the fibroscan uses, basically, where it measures the liver stiffness. But of course, so it gives you a good assessment, but there are certain limitations. So for example, the sensitivity can be decreased in morbidly obese, BMI say more than 40, or if it's in the non-fasting state, or the patient has congestive cardiac failure. Your magnetic resonance elastography, or MRI, MRE scan. This is very, very accurate, high applicability in more morbidly obese or ascitic patients, but of course it is associated with a higher cost. So if you look at when you are assessing a patient for liver elastography or for fibrosis, you can either choose an ultrasound liver elastography, or if the patient can afford it, in Sri Lanka also we now have the facility for fibro scans. It's a bit costly, but it gives you the advantage of a fibro scan is you can have both the liver stiffness as well as the percentage of fat. So you can know, is there any fibrosis, and what percentage of fat is your liver is affected by. Whereas if you just do the other scans, then you would need two of those other scans, one to assess the fat and one to assess the fibrosis. Now, when you talk about, so this is what typically you would get kilopascal readings based on your liver stiffness. So if you look at, say, for example, F0 to F1 would be 2.5 to 7 kilopascals, and this would be mild fibrosis. 7 to 9.5 would be F2, which is a significant amount of fibrosis, and 9.5 to 12.5, the cutoff is to define F3, which is severe fibrosis, and then 12.5 and above is F4, which is basically cirrhosis, right? And these are the liver stiffness cutoffs that we use, and when you compare it to your fibrosis staging, such as a Metavir, which is a histological staging, where you have F0 means no fibrosis, F1 is mild fibrosis, portal fibrosis basically, F2 is moderate fibrosis, which is periportal, where you have some bridging, basically septal involvement, and F3 is advanced fibrosis, where you have significant bridging but no evidence of cirrhosis, and F4 is basically cirrhosis. So when you talk about fibrosis, so fatty liver, remember, is a reversible condition, right? And even fibrosis is reversible up to early F3. So F2 definitely is reversible, and certain cases early F3 can also be reversed. But once you are in F4, then of course it is irreversible, right? Now, this is a reading. This is again a reading that you get when you do a fibroscan. It is called your controlled attenuation parameter, right? And this basically tells you you have a CAP score, and that classifies your steatosis grade, like I've shown here: S0, S1, S2, S3. So based on that tells us. So for example, if your CAP score is say 250, that would be S1. That means 11 to 33% of your liver is affected. If your CAP score is say 300, that means your steatosis grade is S3, where you know more than 67% of your liver is affected. So the controlled attenuation parameter is a fairly reasonable assessment of the amount of fat deposits in the liver. So this image basically tells you what I've just highlighted over there, and just to kind of tell you the average duration, sometimes from simple fatty liver to MASH or NASH, it can take sometimes 5 years, and each of the fibrosis stage typically another 5 to 7 years. So it's a long process, but certain predisposing factors, and if there are certain risk factors which can accelerate this process, right? So like what I've shared with you earlier, like type 2 diabetes, being morbidly obese, or if you have a certain genetic variant, so you need to be a bit mindful in those kind of patients. Okay, so when we talk about the management of fatty liver or metabolic dysfunction associated steatotic liver disease, there are a few areas that we need to focus on, right? So one of it, the most important, of course, is your diet, right? So typically, it should be a low calorie, because you don't want to add calories. All the added calories will end up reflecting with fat deposits on your liver. So low calorie, low fat. Fructose is a significant driver of lipotoxicity. So that is why we tell them specifically they need to stay off, avoid fructose rich food items, right? Some people do intermittent fasting. That's a good way of kind of reducing your overall daily calories and reducing your insulin resistance, and reducing weight. So it works well for them. Weight loss. Now, when we talk about weight loss, I think if you look at all the literature in terms of managing fatty liver, one of the main proven things they would tell you is targeted weight loss of about 7 to 10% in somebody who is overweight or obese, right? But say if your BMI is within the normal range, even losing 3 to 5% can have a significant effect, right? So those who are overweight and obese only, we say 7 to 10%. And remember, when we talk about weight loss, it's not necessarily the BMI. It's basically the visceral fat that we want you to get rid of. And that is why when you talk about exercise, we encourage them to engage in moderate intensity aerobic exercise, right? So minimum 5 hours a week in terms of your cardio component. But it is also crucial that we ask them to engage in some form of resistance training exercise. That is either in the form of bands or weights, where they need to build up more muscle and get rid of the fat and replace the fat with muscle. And I think that is important, right? The other common question I get asked is, okay, if I'm consuming just a small amount of alcohol, can I continue doing this now once I've been diagnosed with fatty liver? So the answer, unfortunately, is no, right? Because even if you consume a little bit of alcohol, all what I've mentioned in terms of those processes are significantly enhanced. So that is why the based on guidelines, even a small amount of alcohol is technically bad for you, and we tell them to abstain from alcohol. It is very important to control other metabolic issues that the patient may have. So, for example, if they are diabetic, you need to ensure that they have an HbA1c to target at about 6.5. And of course, if they have dyslipidemia and other or other risk factors, we would start them on a statin and optimize your statin dose. And of course, we also have to talk about CVD risk factor reduction, because if you recall, the main mortality, or in terms of the significant risk factor in terms of in case mortality for fatty liver patients is a CVD risk factor, either a heart attack or a stroke. So it's important that they reduce that risk in terms of stopping smoking and manage their CVD risk factors optimally. So I'm going to talk to you a little bit about food, right? So I think it's important to understand. So we advise them to have a Mediterranean diet, so a lot of whole grains, right? Unsaturated fats are very good, and you need to reduce saturated and trans fats, right? So lean proteins and so the key things is basically to avoid any fructose. So when what I mean by fructose is any soft drinks, fruit juices, right? Anything with high fructose corn syrup. Okay, so your pastries, your donuts, eclairs, right? All these, anything that has refined refined sugar. Anything that has refined grains or process would have sucrose. Sucrose also is 50% glucose, 50% fructose. Okay, so that is something that is very important, and minimizing saturated and trans fats as well, because like I mentioned, it's a metabolic issue as well. So you want to reduce your risk of developing heart disease or stroke, and alcohol, staying away from alcohol. I think that is very important. Okay, so the other common question that I get asked is, what about fruits? What about the fructose in fruits? Okay, so the issue here is, if we talk about the fructose load, right? So technically, if you look at the fruits, there are certain fruits that have a bit more higher fructose than others, right? So for example, watermelon, apple, mango, grapes, pear, jackfruit, lychee. But we don't need to ask them to avoid it completely, because I mean, if you look at fruits, generally the maximum fructose you would get is probably, say, somewhere between 8 to 10 in the high fructose fruits. 8 to 10, I don't very rarely it would exceed 10 grams per serving. But compared to a soft drink or energy drink, or these artificial fruit juices, even though they say 100% no added sugar, 100% fruit juice, all of them have a high fructose corn syrup, and there you're getting about 2.5 times the loading. And what happens also with fruits, so they can eat fruits is okay, it's not a problem. Fruits is okay, it's just that of course you won't want them to binge on several mangoes at one go, right? Or eat a whole watermelon, that kind of thing. So they can have moderate amounts, that's perfectly fine, because when you eat fruits as well, remember the whole fruit has a lot of fiber as well, so that slows the absorption of sugar. Okay, moderate fructose foods, and of course there are low fructose foods which are very good as well. And we tell them, so for example, eat the whole fruit rather than have it in a juice, because when you juice it, the fructose load and the hit is much faster. Okay, so just going to talk to you a little bit about drugs and certain medications, because I know, I mean, some of these we don't routinely use over here in Sri Lanka because of the cost. But GLP-1 receptor agonists, right? Semaglutide has been extensively studied for fatty liver patients, and these were basically there was a trial that was done, and this data was published, I think, in 2021 in the New England Journal of Medicine, where they looked at a population of biopsy-proven NASH patients and put them on semaglutide 0.4 mg a day, not once a week, a day, and this resulted in 59% of NASH resolution without worsening of fibrosis, compared to 17% in the placebo group, right? So I think there's a lot of hope for this, and in fact things like tirzepatide, which is a dual GIP and GLP-1 agonist, is showing increasingly optimistic results, and may even be better than semaglutide. So there is a lot of research that is ongoing, but the problem with these is it is very, very costly. Okay, so bile acid metabolites and fascinoid X receptor agonists, there is some talk about, but again we don't have these available for our use in Sri Lanka or in other developing countries due to the cost. Pioglitazone, we do have it, we do give it for diabetic patients, but if you look at the guidelines, basically advocate the guidelines for pioglitazone in fatty liver is basically, if you are diabetic, you have type 2 diabetes, and if you have biopsy proven NASH, then there may be a role in it, right? Bariatric surgery, we do know that this is very prominent. I mean, it's one of the most potent therapies to reduce weight loss in a selected group. So it's not the first line for fatty liver, but if the patient is morbidly obese, definitely we would consider this. Okay, so I think a lot of people have this. So the other common question that we get asked is about vitamin E, right? So is vitamin E, should we prescribe it to fatty liver patients? And we do see, I think, some liver specialists also using it for selected patients. So if you look at vitamin E, the literature, basically the European Association of the Study of Liver in 2021 suggested that it may be considered in non non-diabetic and non-cirrhotic patients with NASH, right? So, I mean, the data for this is based on the prevalence trial, which was done in 2010, and it was published in the trial was published in the New England Journal of Medicine in 2010, where they looked at high dose vitamin E, about 800 IU a day, it's important that we understand that this is only in a non-diabetic population, non-diabetic adults with biopsy-proven NASH. Now, this is very rarely that we have biopsy-proven. We don't do biopsies regularly because there are certain long-term safety concerns. We talk about hemorrhagic. There was a study which showed a slight increase in all-cause mortality and a slight increase in hemorrhagic strokes, especially those who may be on anticoagulants, and a questionable risk in terms of link with prostate cancer. But so we use it because if you look at the literature, it basically tells us, look, it does bring down the liver blood test. Your ALT levels may reduce, the MASH-NASH resolution, but in terms of its effect on fibrosis, there is no clinical evidence. So there is no, the overall consensus is there is no benefit in MAFLD patients without NASH. So in certain biopsy-proven NASH patients, we would use it. Now, ursodeoxycholic acid, this is also something that has been used in MAFLD patients in India, and I think some use it in Sri Lanka as well. Again, based on the guidelines, it's not recommended as routine treatment or standard of care, right? The literature shows that, yes, it may have a modest effect on bringing down your liver enzymes, but there is no evidence on it actually improving NASH or MASH or fibrosis for that matter. So future options, yes, there are a few things in terms of thyroid receptor beta agonists, resmetirom, which is under there's a lot of research, ongoing research, and this is something they may consider in the future. So I think in terms of, I've got just 2 more slides to end. So what this slide basically tells you in terms of when should you refer your patients to a specialist, right? So if you do your fibrosis FIB4 screening and it comes in the high risk group, of course you would refer them. If you do some form of liver elastography measurement and it's more than 8 kilopascals, which is basically fibrosis F2 and above, you would refer, right? If you do an imaging, say your ultrasound abdomen, and you do find evidence of portal hypertension or any elastography comes back with the form of cirrhosis, you would definitely refer. If your liver function, your transaminitis is persistently elevated or worsening over the months when you monitor your patients, if you notice that the AST is beginning to increase more than the ALT. So that is a significant fibrosis indicator, may indicate fibrosis, right? So you need to refer them on. And of course, low platelets, low albumin, or if your INR starts to increase. The other thing is if you are uncertain of your diagnosis. So for example, you have fatty liver, but you cannot identify any metabolic risk factors, right? Or you feel that there could be coexisting, they may have an autoimmune hepatitis on top of their metabolic associated dysfunction, steatotic liver disease. So those kind of cases may be a bit more complex, than we would consider referring them. And if you have any symptoms of decompensation or complications of portal hypertension. So I think what is important for us to kind of understand, or the take-home summary should be that if you come across someone with fatty liver, we need to actively follow up, right? So I think it's important to educate them, counsel the patient on the natural history and complications. They need to understand, yes, it is reversible, but they need to understand if it persists. And if fibrosis starts settling in, what are the implications, right? Always screen for metabolic dysfunction, optimize control of metabolic comorbid conditions, and then you can screen them on a regular basis for fibrosis. So for example, the FIB score typically could be done once a year or once in every 3 years, and also refer high-risk patients to a specialist. The other thing that I would like you all to do is in now you understand the link between diabetes and fibrosis. And when you are managing your diabetic patients, actively think about when you're screening them for other complications associated with diabetes. I think it's important for you to understand that fatty liver should be one of them. And you need to actively screen for especially in that population, because the progression of the disease in that population is much faster than somebody who may be not diabetic. And I think it's important for all of us to kind of adopt a preventive health response to MAFLD, because this is, like I mentioned, it's a silent epidemic, and community-based strategies directed at reducing the incidence of the risk factors are extremely crucial. These are my references. Thank you. I'll be happy to take any questions.
Thank you so much, Dr. Sabith. That was very useful. So please ask any questions if you have any. I don't think there's anything on the chat at the moment. Well, maybe I'll just ask one question. In terms of the follow-ups, you said annually or every 3 years we do the Fib4 score. Should we also do the ultrasound scan as well to check?
Okay, so when you mean ultrasound, what do you mean? Ultrasound, the elastography?
Just the regular ultrasound abdomen, because you say anyway it's not quantitative, but often you see patients coming and saying, "Oh, we'll do it annually," when they have their fatty liver. They themselves sometimes do it and come.
So that's a very good question, Kala. I think that's a good question. So I think when you talk about screening, so when you do your Fib4, right? And if your Fib4 identifies them at low risk, that's it. You don't need to do any further, technically, you don't need to do any further fibrosis screening, right? But if they fall into an indeterminate group, right? Where, say, for example, you or say the patient possesses the risk factors, and you want to do some form of liver elastography. So then you would order for an ultrasound liver elastography or a fibroscan. Right. So if you order for an ultrasound liver elastography, that is a specialized ultrasound scan that does the liver measurement for stiffness. Right. Now, the fibroscan gives you two things. One is it gives you the liver measurement in terms of your kilopascal, and it also gives you your CAP score, which is your steatosis grade. So that is why people are now moving towards ordering a fibroscan, because that you are able to assess both the steatosis grade as well as the fibrosis grade. You understand? But the steatosis grade is mainly just for your own, so that okay, has it improved or not? Clinically, there may not be that much significance. The more important thing is your fibrosis. So when you talk about doing a fibroscan, and if your fibroscan is perfectly okay, it shows that you have fatty liver, maybe steatosis grade 1, but there is no evidence of any fibrosis, then you may want to routinely repeat that maybe in about 3 years' time. Right? 3 to 5 years. I'm talking about a fibroscan. But every year you can do your Fib4 score. Right? Even the Fib4 score, you can do it 2 years, because we know the fibrosis, it takes a longer time. Right? So if, say, for example, the patient cannot afford a fibroscan, because fibroscans are very expensive, right? Then when you are ordering an ultrasound liver elastography, then you order an ultrasound abdomen to just check the fatty liver, whether there is any.
Right.
But that is very, very subjective, right? That is why it's not done routinely. So it's mainly an incidental finding, the ultrasound abdomen. A lot of us, we order it for something else, and then it comes back as grade 1 fatty liver, grade 2 fatty liver. Yeah.
Right.
Is that clear?
Yes, thank you. Yes,
Yeah.
thank you so much. There are some questions on the chat.
Sure.
Dr. Fatima has asked, can you please explain about AST, ALT, GGT evaluation again, as they are available at primary care level?
Yeah. So basically, when you talk about your liver function test, a normal liver function test doesn't tell us anything, right? You can have a normal liver function test, and the patient could have MASH or metabolic associated steatohepatitis. Patient could have early fibrosis, and your liver function very early stages, your liver function test could be normal, right? Now, if there are certain, so a normal liver function test doesn't mean anything. But say if you feel the patient who has a slightly elevated GGT. Now, GGT, there are many causes that can cause it to be raised. So alcohol is typically one, but when we talk about GGT with alcohol, it's significantly raised. But some of what I'm talking about is the most sensitive marker between your ALT, AST, and GGT. The first marker to raise is your GGT, which may be slightly above the upper limit of normal, right? In certain patients. Now, so that's something that is important. So if you see a person with persistently elevated GGT, and you do your ultrasound, they don't consume alcohol, or their alcohol intake is not significant, and on the ultrasound abdomen that you order, they don't have any issues, then you must always think about, okay, could this be fatty liver related GGT rise? Now the ALT subsequently will go up if there is some form of inflammation, but like I mentioned, not always. But if you notice your AST going higher than your ALT, and once your AST starts to rise, AST is a reflector of fibrosis, because the increase in AST occurs when when fibrosis starts. You know what I mean? Is that Fatima? I hope I've answered her question. But use it. Don't a normal liver function test means, so that I have a lot of patients who come and tell me, my liver ALT, AST was high, now it's come back to normal, I've been cured of my fatty liver. That's a wrong conclusion.
Yeah. There's another question, Dr. Sabith. This is from Dr. Janith Vijayanayaka.
Yes.
When using the FIB4 score, is it exclusively for patients with fatty liver disease, or can it be used for HCV and HBV infection as well?
Yeah, of course. So initially the FIB4 score was designed and validated for HCV and hepatitis B, right? That's what I mentioned during that slide. It was used to find out before how bad the to screen them, whether they require biopsy or not, right? So, but it has also been used. So that was the original design of the FIB4 score, but it has also been validated for use in MAFLD patients, or metabolic